Okay.
Live.
Live.
Yay!
Hey, welcome everyone. We'd like to welcome you to the next edition of the Rheumatology Nurse Practice. This is our Google Hangout, and we'd like to apologize for a little bit of a late start. Technology is an amazing thing, and it also can be a significant producer of pain. Sounds like we have a nice loop back here. So, okay, sorry about that. We actually had a little bit of a loop back on our audio. Sorry about that. So anyways, we'd like to start tonight with RA and comorbid conditions, focus on pain management. And our faculty tonight is Sherry Carter. She's a PhD RN. Jackie Fritz. She is a RNBC MSN CNS. And I'd like to also add Sherry Carter is also an RNBC, and that is a board-certified rheumatology nurse, as well as Ellen Schreiner, our guest tonight. And so I'd like to hand this over to Jackie right away just so we can jump into our discussion, and we'd like to get into this on pain management.
Hi, good afternoon. We are going to go through pain management. If you have questions, you can, we'll go over how to ask those questions, but today, we're going to go back and ask that now. So you can use the question answer feature on your Google Hangout on the AIR platform, or you can use Twitter, and it's number RNP16, or you can use Google voice text line to send a question. The phone number's there, 267-689-8495. So please interact. Don't let us just sit here. You know, if you have questions, chime in. So we're going to talk about the different types of pain: acute, nociceptive, neuropathic, central, peripheral, some mixed, visceral, and of course that horrible catastrophizing pain. We're going to talk about some of our pain assessment tools in our individual practices, whether you use HAC or DAS or whether you use CDI, and do you use pain assessment tools that are subjective or objective or a mix of both. And then we're going to go through a little bit of a thorough review of safe practices for opioids in use in the patients with RA. We know that the opioid crisis in the United States is a hot ticket, and that's why we've chosen to talk about it, because our patients really do have pain. But it really stresses the point that it is a multidisciplinary problem. It's not just one person's problem. It's not just the patient. It's not just you alone. We have a whole team together that needs to address this. So moving on to the next slide, since pain is an RA complaint, we're really doing a lot better. We're now looking at T to T, treat to target, because our goal is remission. We have biologics, we have DMARDs. But wait, 40% of our patients are on opioids, and we really want to avoid that catastrophizing pain, because pain is a fifth vital sign. It's not just a number. One of the docs said yesterday, if I don't give opioids, my patient gives me a bad rating, so I have to give opioids, right? I don't think that's the answer. So that's what we're going to talk about today, is how we can make our patients feel, empower them with knowledge to help them manage their pain, so their satisfaction survey shows that they're part of the plan. So looking at our next slide, we're going to talk a little bit about how does RA affect the body's organ system, what factors impact our patient's individual concept of pain, what else can we do besides just give pain pills? There must be more to it than that. So if you look at our next slide, we're it, you guys. If you look at ACR or EULAR, the guidelines are mentioned. There's no mention of pain in management. There are 11 key principles of pain management that were compiled by international consortiums of rheumatologists. So we need to work together to add this criteria to ACR and EULAR guidelines. So we have a case study that Ellen and Sherry are going to help work through, and hopefully that'll help us all understand how we can effectively manage the pain for our patients a lot better. So let's get started, girls.
Thank you, Jackie. I'm going to go ahead and get started with it right now if we can get started with our case studies. And, you know, I was thinking about taking it easy and being nice to our guest, Ellen, but then, you know what? What would, you know, she's an expert. Hey, let her teach us. Let her help us on our complicated patients that we have. So I have given her a pretty typical patient for us. We have a 55-year-old female that presents in the office. She's a 3-pack a day smoker, 3-pack a week smoker for 30 years now. She's been diagnosed with rheumatoid arthritis about 7 years ago and osteoporosis 2 years ago. Additionally, because we all know you just don't have RA alone, she's had Raynaud's and IBD with constipation and also GERD. She has hypertension, which is controlled, thank goodness, by her medication. She has chronic urinary tract infections and bronchitis. So to make matters just beautiful, she's developed her menopause symptoms about 9 months ago. So she's had an extreme weight gain recently, a lot of depression, mood swings, the hot flashes. Some of you all out there know exactly what I mean. Now, she comes in with a chronic stabbing type pain in a pinpoint location around her left hip area just below the belt line, and it radiates horizontally, not laterally like we'd think, and it causes her to have an occasional limp from the discomfort and the frequent need for her to change positions. Well, she can't stand or walk for more than 30 minutes at a time without pain restricting her in that left hip. And she also has a very slight leg length discrepancy on that left side. Now, the RA symptoms that she deals with on a constant basis, that we're using a verbalized pain scale of +1 to a +5. She has pain at a +3 bilaterally in her knees and in her thumbs. She has cervical neck pain, and of course, with her osteoporosis and adding years to her birthday, she's got stiffness and slight kyphosis in the area of her neck. Now, the medication that she's on includes methotrexate, and this is by sub-Q. Decided to go to this for her because she is a rather large woman, and it just seems to be better effective on those. Y'all may disagree or you may agree, but 25 sub-Q. She's on Plaquenil, 200 milligrams in the morning and evening, a slow-release prednisone for her just joints that are inflamed. She is taking Arthritic for pain, 75 milligrams in the morning and the evening, and also to help that breakthrough pain, which she apparently is experiencing all the time. She's taking Tylenol number 3 to give her 60 tablets, 60 milligram tablets, and she's to take 1 or 2 every 4 to 6 hours as she's needed for pain. We've now gone to giving her just a 2-week supply at a time and trying to tell her to use it sparingly. So try to make it spread out. Don't depend on that Tylenol number 3. Let's see if we can find other ways to help relieve your pain. And that doesn't seem to be any good because she's calling back the office. You can go to the next slide. She's calling to the office for more help with this frequently. Her additional medicine that she's on is Fosamax. She's on Wellbutrin in the morning for her depression and anxiety. She's on Prozac at night for her mood swings, and we did try Celebrex, but she didn't respond well to that. She's on the Benicar that is for her blood pressure, and she just takes one tablet in the morning, and that seems to keep her well controlled on her blood pressure. And also, her primary has put her on recently Lipitor, 40 milligrams at bedtime. Further on to the RA assessment, we've done her DAS in the last 3 visits, and she's visited us very frequently. It's been at least every 2 months when she's been coming in. So her DAS 28 scores have been, and that's using erythrocyte sedimentation rate, a 5.9, a 5.8, and a 6.3 for the last 3 visits consecutively. Also, we do a HAC2 self-reported short form for her. The last 3 visits, she's right at 20, 20, and 20 points for that. Now, we're going to refer her to the pain clinic. We're going to refer her over to Ellen at this time for assessment, because she has just called frequently and says this pain, this constant pain, is just not working. I mean, I can't get any relief by it whatsoever. And we've tried our methods that we know. And we have been perhaps a little leery of the opioids. So we want to see what Helen has to say to help us with this.
Next slide, please. Okay, so our patient shows up at the pain clinic, and let me tell you that she's not unlike probably 90% of our patients. They've been through multiple medications, trying everything, to see what could relieve their pain, and they usually come to us when they've tried everything and now no one else has any other ideas. So the first thing that you would do when they came to us is we'd look at everything that you guys had sent to us. So I reviewed that case study, and we would do a physical and a history taking of our own in addition to see if sometimes people leave things out or they don't think it was important to tell. So we would do another history and physical, and then actually do a complete pain assessment. And that's really important, because not only does it look at what they've tried in the past, but it also kind of gives us a guidance as to where we might want to go. And one of the forms that I've used in the past is called a WILDA assessment, W-I-L-D-A. And so you ask a couple of things. You ask for the words that they describe the pain with. So is it sharp? Is it dull? Does it radiate? Is it electrical? What does it feel like to them? Their intensity, a pain rating, for 0 being no pain. We go a 0 to 10, but some places do the 0 to 5. So that's your I. Your L is the location. Where is it at? Is it pinpoint, like you said you can pinpoint it with one finger, or does it radiate throughout the whole their whole body? And then the last is the duration. How long does it last? The A part of it is what aggravates it. For her it was walking. The walking makes it worse. So you put these things all together and look at where do we go from now? With this, because we don't have any physical or any studies or scans or anything, we might ask that we get maybe a hip x-ray, maybe an MRI to see what's going on there, maybe a low back, because it could be pain that was radiating into her hip, starting in her low back. And once we had all of that done, we would then look at adjusting medications. One of the other tools that we use is an opioid risk tool, and we use that not to decide whether or not we're going to use an opioid or not, but more or less to see what kind of likelihood might it be that the patient would become, everyone will become dependent on it, okay? It's a physical tolerance. Anytime you take a medication like an opioid for more than 21 days, your body becomes physically dependent on it. So it's important that we explain that to her, that the medications that we do use do cause a dependency, but it's not an addiction, so to speak. The opioid risk tool kind of looks at, what are the likelihoods that they may have a problem using this? Do they have a history of other substance abuses? Do they have a family history of substance abuse? Things that might make us a little more cautious as we begin prescribing medications. Once we have all that down, we would then talk about the interactions with what was there and why did some of these things not work. I have to tell you, the first thing I did was run an interaction on all of those medications when I looked at it. And amazingly, the two drugs that you were using the most of, Arthritis and the codeine, are the ones that have the most interactions with methotrexate, which I've found interesting. So that would be something that would automatically tell you those are going to give you poorer results. You're going to not have them as effective just because of the other medications that she was on. So what are those potential medication interactions, and how does that affect the patient's outcome? Should we look at a low-dose opioid? Opioids have gotten a really bad rap lately, and I don't totally disagree with it, but I think that the people that are kind of getting lost in the shuffle are those people that do have chronic pain and need something to allow them to function. So we talk about the usefulness of opioids, but we also talk about what else can we do besides just give medications. Maybe we need to look at some physical therapy. Maybe we need to look at some biofeedback. Other things we've used were guided imagery. Sometimes we need to include our psychologist to see, what all is going on. Anytime somebody's in a chronic pain condition for any length of time, depression gets to be really a significant part of their, basically their disease. So if we're not treating all aspects of it, we're not going to be successful. Most people say, oh, I don't need to see that psychologist, I'm fine, and it can't be a pick or choose type of treatment plan. If you start letting people pick and choose, we come to a situation where we're not as effective. So we give them a whole range. We're going to ask that they get an evaluation by our psychologist, possibly ask that they get an evaluation by the physical therapist. Maybe they need to do some core strengthening or just movement alone that will help keep those joints lubricated. Then we would also possibly start them on then a low dose of an opioid. The issue with that is you'd have to give it a short period of time, and in order to continue on it, we need to see progress in their activities. So a lot of times we'll say to the patient, what is it you would like to do? What is it that your pain is preventing you from doing? Maybe it's going to their kids' plays and being able to sit at a game and watch a sporting event. Whatever it is that they feel is important to them, we want to see that they can return to. If the low dose of the opioid's not doing that, then we need to look for another alternative. You can't just keep increasing the opioid without seeing any improvement in their function. So that's a lot of education on the part of the patient, because they need to know what we're going to be looking at. That'll bring them back to the office probably every couple of weeks for a month or so till we see how they're doing. And in addition to that, get all the other disciplines involved. The fourth piece of the education process of our patients is the safe storage, and what do we do with these medications in the home? Where are they going to keep them? How are they going to keep them away from other people? They need to understand that these are very potent medications. They're very useful when they're used as intended, but they can be deadly if misused or in the wrong hands. So they want to make sure that if they have kids in the home or they have people in and out of their homes, that these medications are stored safely. And that's basically the education piece. And then it would be the follow-up of seeing where they're at functionally. Low-dose opioids for the most part, and I'm talking a long-acting opioid so that they're not taking a pill every 3 or 4 hours, but they're maybe taking it twice a day so that it's not a main part of their daily routine. You want the medication not to be the focus of their day. Oh, it's been 4 hours, I need to take that pill again. We want them to just have it be as much a part as the rest of your medications are. You don't worry about your blood pressure all day long by saying, oh, I better check my blood pressure and take my pill again. We want that pain medicine to be in the same thing. You take it twice a day and you move on with your life. And that's pretty much the evaluation then that will be done in the pain clinic.
I love your idea, Ellen, of empowering them by saying, what is it you miss? I think that's a great place to empower your patient. What do you want to do? Do you want to go to your kids? I love that. I think that's a really nice intro to get the patient involved. I think
it's important. Right. I think it's important that we know what they want to do. Not, I want you to take 2 pills a day and no more. What is it that you want to do that this pain is keeping you from doing? So that we have a goal. You know, maybe it's just sitting. I used to tell people, if you just want to be able to sit at the dinner table at night with your family for a meal, then that's what we're going to focus on. Getting you comfortable enough that that's what you can do. Because it doesn't really make any difference, quite honestly, what we want them to do.
You're so right.
Ellen made a great point, too, that I think it's important for the nurses to know and feel comfortable with the fact between physical dependency and addiction and the length of time that it would take for either one. So I think, I wrote it down, 21 days for a physical dependency, and that's not necessarily an addiction. Right. So if we can feel comfortable with that and help our providers to feel comfortable with that, maybe we can alleviate some of the upfront acute pain.
Right. And you also have to make sure that you're giving them enough medication to allow them to take what you're prescribing. So let's take your Tylenol 3s, for example. If you're asking them to take, 2 to 3 a day, but you're only giving them 60 pills, how long is that going to take them? That's not going to take them 2 months. That's not going to be a 2-month supply.
Right.
So then people start calling early because I ran out. Mm-hmm. Well, they ran out because they were taking it as it was prescribed. So we have to be careful with that too, that we don't assume that because they're calling for a refill that they're misusing it. We have to be sure that our prescription matches what we've ordered. Okay, so if I tell somebody you can take this pill twice a day and it's going to last you for a month, then I should be giving a prescription for 60 pills. So that the patient then understands this has to last a month.
Excellent point.
Yeah, I think that's great, Ellen. I like the interactive disciplinary that, you tell them straight off the bat, you need to go to a psychologist. This is not just this makes you sad that you have pain, and it's okay to be sad, and we're going to work together again to that goal of doing whatever, sitting at the dinner table with your family or going to your baseball game. I think that's just awesome that you allow them those feelings. I think that's really, really important in this arena of pain.
One of my colleagues, when I first started in this, told a patient, it's kind of like depression and chronic pain go hand in hand, kind of like spots in the measles do. You don't get the measles without the spots. And you can't have a chronic pain condition without some type of depression. It just is not, it wouldn't be normal. So that always made people kind of go, well, yeah, I guess it is all right then. It's okay to be depressed, but we have to treat it. We can't ignore it.
Do we have any questions that were brought in? Kevin?
Did we lose Kevin?
Nope, we're on. We do not have any questions at this point. I think everyone's enjoying the process. I think that was a great discussion as far as treating not only the pain, but the depression and everything that's surrounding it. But we do want to thank everyone for coming. Any final comments from our panel tonight?
I just think it's us. It's us that practice rheumatology every day that have to help add pain measures to EULAR. I think that's important that we look at that and that we add that ACR and EULAR adds that, I think, to their treatment guidelines. I think that's really important. And I think the more education we as nurses and nurse practitioners and DMPs, I think people like Ellen and Sherry and all of you out there, I think it's our job to help make pain be part of the treatment guidelines. I really, really do. And I think we will. I think we will.
Yeah, I think I'd have to add too, especially where the opioids are concerned now. Just look at the evidence. Don't just weigh all the hype out there with what you see in the evidence, so you can help your patients with that best decision possible, and get them the results that they need on a personal one-on-one basis.
Absolutely.
We would help each other, all of us, in the care of the patient. Ellen, you guys, I think that, thank you. I think we're off to a roaring start to make this even better than it's been.
Yeah, it seems like there's a lot of opportunities for us to collaborate with our organizations and considering pain management and treatment of RA and all autoimmune diseases and inflammatory disease out there. There's much more to learn about this. A couple of wrap-up notes. First off, thank you for joining us. We had a little bit of a rough start going on, but that's technology for you. But thankfully, we got a lot of great information shared. And thank you, Ellen, for joining us tonight. Sherry Carter, of course, and Jackie. And many of y'all may not have heard yet. You'll see some more information. But Jackie Fritz is actually the Rheumatology Nursing Nurse of the Year, recognized at our conference just a couple of weeks ago in Cleveland in 2016. So, Jackie, you're much appreciated and loved by your peers, and we appreciate you being on this panel with us tonight. We'd also like to ask you to join us on our website at rnsnurse.org/RNP. You can sign up for the free editions of the Rheumatology Nurse Practice, which is a great evidence-based publication coming out. We actually have the next one coming out on pain management. It should be in the mailboxes probably sometime the end of next week to begin the week after that. We're finalizing that in press right now, so we look forward to having that. We'd also like to thank everyone who came out to our conference in Cleveland in 2016 this past couple of weeks ago in August. And we've announced now that our 10th anniversary conference will be in Orlando, Florida, where it all began. And we'll be on August 9th through 12th in 2017. And we hope to see you all there at the Gaylord Palms Resort and Conference Center. So finally, thank you again, panel. We thank you for everyone who joined us and are watching this as a replay, and we look forward to providing you with much more great evidence-based education and discussions in the future. Thank you, everyone. Have a good night.
Good night.